Bismillahirrahmanirrahim. Salatu wassalamu ala Rasulullah sallallahu alayhi wa sallam. Today we are going to talk upon rheumatic heart disease. In our previous talk, we learned what is the acute rheumatic fever, and then after covering the acute rheumatic fever, we talked about what are the consequences of the acute rheumatic fever and how it can be prevented. Now we are going to start with the rheumatic heart disease. Means when rheumatic fever is over, then it is leaves its complications and results in some disease, especially valvular disease. Mitral valve disease is most common, followed by the aortic valve disease and other valvular disease as well. So now we are starting with the first mitral valve disease. So we will cover today the mitral valve disease. And among the mitral valve disease, we will discuss the mitral valve stenosis, and then we will start with the mitral valve regurgitation, and quickly we will complete today the mitral valve disease. In next lecture, we will cover the aortic valve disease. So you know the mitral valve mitral stenosis. Before knowing the mitral pathophysiology of mitral stenosis, you must learn the what is the normal anatomy of the mitral valve. So you see, mitral valve is situated between the left atrium and left ventricle. The mitral valve apparatus consists of mitral valve leaflet, cardiotendiny, atrial muscles, and mitral annulus. The normal valvular area for mitral valve is 4 to 6 centimeters, and the annular size for the normal mitral valve is 10 centimeters. So this is just the anatomy, and you can see the capillary muscle there. So the commonest involvement of the mitral valve and mitral valve disease, mitral stenosis, the both valve and the subvalvular apparatus both are involved, and commonly the cardiotendiny and the annulus and the mitral leaflet itself are involved, and then in some cases, the atrial muscle are also involved in cases of mitral stenosis. You see, this is the echocardiographic view and the structural presentation of the section of myocardium. You can see the different structures. There is a left atrium, and there is a left ventricle, there is a left ventricular outflow tract, and there is the aortic valve and aorta, ascending aorta, and right ventricular outflow tract is also seen in this picture. You can see RVT here, you can see the left ventricular outflow tract over here, you can see the aortic valve here, and the coronary sinus over here, and the aortic valve over here, and this is the left atrium, and pulmonary veins open into the left atrium, and through the blood from the left atrium through the mitral valve comes inside the left ventricle. This is how the ventricle fills from the left ventricle, and normally there is no obstruction to the flow through the mitral valve. And then when blood comes into the left ventricle, then it goes towards the aorta through the aortic valve. So this is the normal flow of blood during the diastole and systole of the heart. Blood flows from the left atrium through the mitral valve, and in systole from the left ventricle across the aortic valve into the ascending aorta, and then the system circulation, whole system circulation. So what are the common causes of the mitral stenosis? You see the congenital heart disease. Among congenital causes, there is parachute mitral valve, supravalvular mitral ring is there, and there are some systemic causes that can produce mitral stenosis. This is the massive annular calcification, systemic lupus erythematosus, carcinoid syndrome, metastasized and any patient who has got previous episode of endocarditis, then you can have after healing endocarditis, the adhesions of the valve and the pituitary muscle endocardia occurs, and there is stenosis of the mitral valve. So again, it is sequelae of endocarditis, mitalosis can occur, and in some cases of rheumatoid arthritis, this is one of the connective tissue disorder in which the heart valves are also involved, so you can get mitral stenosis. But again, the commonest cause of the rheumatic mitral stenosis is the rheumatic fever and the post sequelae of the acute rheumatic fever. So rheumatic remains the commonest cause of the mitral stenosis. See, the what happens in case of mitral valve stenosis, the normal area we saw that this the normal area is the for mitral valve 4 to 6 centimeters square, and but it is reduced when there is a inflammatory process due to valve abnormality. You can have a thickening and the fusion of the different valvular apparatus. Abishas can be thickened and adhered with each other, and even cusps can be adhered with each other or with the body, and sometimes even papillary muscle, and all these valves, annulus and cusps and the body and papillary muscle get adhesions, and there is severe mitral stenosis. So actually, this is the inflammatory process which results in the fibrosis and adhesions of the different commissures and cusps. They adhere each other and reduce the mitral valve area. And whenever there is reduction in the mitral valve area, definitely there will be a reduction in the flow from the left atrium to the left ventricle. So it means when in case of normal mitral valve orifice, the flow of blood from the left atrium and left ventricle is not obstructed, but whenever there is mitral stenosis, there is narrowing of the mitral valve apparatus and the orifice, and you can get reduction in the flow of blood across the mitral valve from the left atrium into the left ventricle during the diastolic phase of the cardiac cycle. So usually you have got commissural and the cuspal fusions which reduce the mitral area. But as I told you, that sometimes the cardi and the pituitary muscle get involved in cases of mitral stenosis when it is very severe disease. So what happens whenever there is a narrowing of the valve? So you can get a decrease in the orifice of mitral valve. And whenever there is a decrease in the orifice of the mitral valve, definitely there will be a gradient across the left atrium and the left ventricle. Means the flow of the blood that was flowing through the mitral valve, normal valve, is now is from the left atrium to the ventricle, is supported by the atrial kick, and there's increase in the left atrial pressure. And whenever there is an increase in the left atrial pressure, definitely this is a small chamber, and this gets more blood into the atrium because the emptying of the left atrium is reduced, and pressure inside the left atrium is increased. So definitely there will be enlargement in the left atrium itself. So one thing is that the pressure gets increased due to decreased orifice of the mitral valve. Second thing is that the left atrium itself gets enlarged. Due to enlargement of the atrium, the patient become prone to develop atrial arrhythmias. The most common atrial arrhythmias that occur in case of mitral stenosis is atrial fibrillation. You see, whenever there is increase in the left atrial pressure, definitely the pressure goes back into the pulmonary venous system, and there is increase in the pulmonary venous pressure as well. And the pulmonary venous pressure, which is increased, this initiates a response into the pulmonary arterial system, and the pulmonary arterial uh, uh, pressure becomes increased. So ultimately, there is pulmonary arterial hypertension as well. And whenever there is pulmonary arterial hypertension, the pressure develops on the right ventricle, because now the right ventricle has to push blood into the pulmonary vasculature with more force, so it gets hypertrophied and enlargement. So whenever there is pulmonary arterial hypertension, you can have a right ventricular hypertrophy, and you can have a right ventricular enlargement. So means the increased airway pressure is the main thing that results into all these complicated phenomena. First step is the decrease in the orifice of mitral valve, and then there is increase in the left atrial pressure and enlargement of the left atria, and this pressure builds up into the pulmonary vascular system as well as in the pulmonary arterial system. So this complicates in reflects back on the right ventricular side, and there's hypertrophy and enlargement of the right ventricle itself. So this is how the pathophysiology of mitral stenosis, and which causes the symptoms in the patient and the complication the patients to appear. And to overcome this reduced mitral orifice, definitely whenever there is a decrease flow of the blood from the left ventricle, from the left atrium into the left ventricle, definitely there will be reduced cardiac output, and this is compensated by increase in the heart rate. So again, when there is increase in the heart rate, this again causes problem with the emptying of the left atrium into the ventricle, and this circle becomes a vicious circle, and patient gets more and more symptoms and a worsening of the disease, and patient will develop symptoms. So depending upon the severity of the mitral stenosis and the orifice of the mitral valve and enlargement of the left ventricle, left atrium, enlargement of the right ventricle and pressure on the right ventricular side, patient gets different types of symptoms. So presentations can vary. Patient can present acutely. Patient can present progressively. Sometimes when there is arrhythmia, then patient can develop severe sudden symptoms. Otherwise, usually there is gradual deterioration in the patient's health and gradual deterioration in the symptoms of the patients. So the usual symptoms are the dyspnea, wheezing and cough, fatigability, diminished acuity, and pace of acuity, and palpitation occurs when there is arrhythmia or even sinus tachycardia or the composition of heart failure. Sometimes patient can present with the pacing complete or fainting episode. So initially the symptoms occur on the exertion, but when the disease produces advances, then you can get symptoms at the rest as well. So again, you can have a cough, wheezing, abdominal nocturnal dyspnea can occur, orthopnea can occur in patient of severe mitral stenosis. You can have a hemoptysis as well. So sometimes whenever there is a huge enlargement of the left atrium, you can have a hoarseness of voice due to compression on the posterior lying recurrent laryngeal nerve. When recurrent laryngeal nerve is compressed by the left atrium, then patient gets hoarseness of eyes as well. And even in a huge enlargement of the LA because it compresses on the esophagus as well. So sometimes patient can present with the dysphagia itself. So these occur in very late case, untreated case of mitral stenosis, or otherwise, in usually cases you will get rarely hoarseness of eyes and dysphagia. This is the case when there is a very severe enlargement of the left atrium, which compresses on the recurrent pharyngeal nerve and on the esophagus. And the typical feature of mitral stenosis that is the mitral fasces. This is actually rash on the cheeks of the patient, purple patches on the cheeks of the patient, and this gives the typical fasces that is known as mitral fasces. And arterial pulse, when you examine the pulse of the patient, usually is normal, or depending upon the severity of the mitral stenosis, you can get a low volume pulse as well. And when you examine jugular pulse of the patient, you can have a prominent A wave in the JVP of the patient, and when you start palpation, examine the chest and pericardium of the patient, you can get a apex beat that will be typically tapping apex beat. It will be not displaced, but it will be tapping in character, and you can find a palpable S1. Actually, this palpable S1 is the tapping apex beat that is fed with the palm of your hand while you are examining the patient's volume. And you can get diastolic fill as well in a patient with severe mitral stenosis, but it is very rare to have a fill in the case of mitral stenosis. But you can get sometimes diastolic fill as well. And in patients who develop pulmonary artery hypertension, and pulmonary artery hypertension results in the enlargement and hypertrophy of the right ventricle, you can get right ventricular heave in the left pastern region of the patient. And in those patients who develop pulmonary hypertension, you can have a loud P2, and this P2 can be palpable as well. But on auscultation, you can find loud P2. Auscultation, you can have a loud S1, and you can have loud P2. And there is an opening snap. This diastolic sound, this is heard during the diastole, and from opening snap there is a start of a murmur that is the typical mid-diastolic murmur of mitral stenosis. So these are the auscultative findings. Number one is the loudest one. Number two is the loud P2 in case of pulmonary hypertension. And open snap. And open snap is the characteristic of the mitral stenosis, especially in those patients whose valves are pliable, means the valves that can be opened by the balloon valvoplasty. So this is a very important auscultative finding. If you get opening snap in a patient who has a clear mitral stenosis, you can say that this patient can be managed with the percutaneous method rather than the surgical method. And mid-diastolic murmur is a typical of mitral stenosis. If you perform electrocardiography in the patient with the mitral stenosis, so in this patient will relieve P mitral, there is enlargement of the and broadening of the P wave on the ECG. You can have a notch on the P wave that is typical of P mitral, and you can have a right axis deviation again in those patients who have got right ventricular hypertrophy and pulmonary artery hypertension. You can have signs of right ventricular hypertrophy. You can have atrial fibrillation. And among the radiological findings, if you have a chest X-ray, then you can see the cardiomegaly, enlarged left atrium, and enlargement of the main pulmonary artery, enlargement of the right ventricle, and you can have a right-sided double contour on the chest X-ray of a patient. And definitely the diagnosis made on the echocardiography, it will say a lot of the things, and this will establish diagnosis. It will look at the anatomy of the mitral valve. You can see calcifications and narrowing. You can measure the mitral valve area. You can calculate pulmonary artery hypertension. You can measure pulmonary artery. You can have measurement of the right ventricular, and you can establish right ventricular hypertrophy, and you can have enlargement of the RA. You can measure the RA, and you can measure the pressure of time for calculation of the severity of the mitral stenosis. So echocardiography is basically the main investigation that will establish and differentiate between the various degrees of mitral stenosis, whether this patient has got mild mitral stenosis or this has got moderate mitral stenosis or the patient has got severe mitral stenosis. And cardiac care, sometimes it is advisable and it is necessary in a patient, especially in those patients who have got older age and where you can have evidence of some coronary artery disease as well. So in a patient who has got more than 40 years of age and with risk factor for ischemic heart disease, and he has got risk factors for ischemic heart disease, then you must go for the angiography before doing any procedure for the mitral stenosis. So this is a mandatory in these patients who have got risk factors for ischemic heart disease and who are more than 40 years. Otherwise, there's very rare use of cardiac catheterization and angiography. But in these set of patients, you can have angiography before going to any procedure that is related to mitral stenosis. So as we discussed that in this picture, you can see that there is enlargement of the RA, and you can see there is enlargement of the pulmonary artery and the left atrium, and you can see there's some pulmonary congestion over there, and you can have a double control of the on the right side. You can see double control. And here is the enlargement of the LA, here is the enlargement of the pulmonary artery, and there is the enlargement of the RA. And you can see in case of ECG, you can have, I say, that there is a notching of the P wave and broadening of the P wave. So you can see that the notching of the P wave and the broadening of the P wave. So this shows that there is the enlargement of the left atrial zero. And even you can say the terminal portion of the P wave in V1 lead, there is enlargement of the LA. And you can see that there is R wave in the lead V1. R wave means there is a enlarged ventricular hypertrophy of the right ventricle. So this is the echocardiography. Especially you can see that echocardiography, as we told you, that this will establish the severity of the disease, and you can on echocardiography you can have a different